Hi guys, I'm Dr. Wallace. I'll be your professor for Pharmacology 1, 2, and 3. Um, this first lecture is really just an introduction to pharmacology in general. We're going to cover a lot of background information and talk through kind of a lot of different topics that all relate to pharmacology and rational prescribing. There's a lot of kind of random stuff that we're going to jump through or cover, but all of the information is really important, to kind of carry forward with us. I want to make sure that you know all of this about dosing or medical math, all the different kind of keywords that are going to be important for us as we learn the more specific concepts related to pharmacology. So this is just kind of our broad introduction before we go into the more clinical science aspect of it. So first off, these courses are titled pharmacology, right? Clinical pharmacology. So what is pharmacology? Pharmacology literally means the study of drugs. Pharmacology can be broken down into pharmacodynamics and pharmacokinetics. Pharmacodynamics is what the drug does to the body. So the drug's effect on the body. Maybe the drug causes your blood vessels to dilate. Maybe the drug causes your heart rate to slow down. It's what the drug is doing to the body. Pharmacokinetics is what the body does to the drug. So when you take the drug, where does the body put it? Does it put it in the bloodstream? Does it put it into your tissues? Does it put it into the brain? Where is the body allowing that drug to go? How the body processes the drug. Does it metabolize the drug? How the body eliminates the drug. Does it eliminate it in the urine? Does it eliminate it in the feces? All of that is pharmacokinetics. Those are the two major aspects of pharmacology. We're going to talk a lot about those two topics this semester because they are extremely important to the way that drugs affect our body. Now, clinical pharmacology is more specific in that it's the study of drugs and how we can optimally use them in humans. So like not just, hey, this is a drug and this is what it does, but how do I actually use this? When do I prescribe this drug? How do I adjust the dose of this drug? How should I counsel patients when I prescribe this drug? All of those clinical aspects that allow you to use a drug safely or optimally in your patients. That's clinical pharmacology. So it's taking pharmacology one step forward. So ultimately, what we're studying in this course is the drugs that you'll be prescribing to your patients so that you can prescribe the safest, most efficacious, or effective medication regimens for your patients. So I keep talking about, optimal use of drugs, the study of drugs, right? So what is a drug, right? I think that term drug has been, excuse me, has been used kind of in society as a derogative term sometimes. Really, we grow up hearing just say no to drugs. But drug is not a derogatory term. We are not defining drugs as a term, for a substance that is misused or abused. For us, drug is defined clinically as any agent or exogenous substance, so substance from outside the body that we're putting either in or on the body. So any exogenous substance used for the diagnosis, prevention, or treatment of disease. So some drugs are used to diagnose diseases. We might, dilate the eyes, for example, when we're doing an eye exam, right? In that case, we're putting a drug into the eyes, anticholinergic drugs into the eyes to dilate them. That's diagnosis. We can inject antigens for allergy testing. That's for us to diagnose specific allergies. We give a barium enema when we're doing imaging studies of the lower GI tract. In that case, we're giving the drug for diagnosis. We can also use drugs for prevention. For example, vaccines, right? Those are for prevention of infection. Anticoagulants are given to prevent blood clots in patients. However, the vast majority of drugs that we prescribe are used to treat diseases, right? We have, insulin to treat patients who are diabetic. We have antihypertensives to treat patients who have high blood pressure. We have a lot of different medications that treat disease. So, why does this matter so much? Why is it that pharmacology is such an important part of your education? I would argue that it's the most important part of your education. Because, you can do everything else right. You can give your patient a great physical exam. You can diagnose them just perfectly. But if you choose the wrong drug to give them, you're not only not treating them correctly, but you could actually harm them more. So, being able to prescribe rationally is incredibly important. So, and really, when we look at, what happens when a patient comes to the doctor, a prescription is the most common outcome of a physician action. So about 2/3 of the time when a patient goes to see a practitioner, they're going to walk away with a prescription in hand. So it's very important that you can prescribe correctly. Improper prescribing affects hundreds of thousands of patients every year. You are going to be the one who's writing the prescription, right? You are going to be the one who is responsible for either creating a good outcome in your patient or a poor outcome in your patient. So when we talk about clinical pharmacology and rational prescribing, we have to kind of look at toxicology as well. Toxicology is very closely related to medication use. It's defined as the study of the adverse effects of chemical substances, right? Or the adverse effects of poisons. So that kind of brings up, the word poison. And poison, I think of, when I think of a poison, I think of something like, bug spray or household cleaners, these nasty chemicals that we know to, stay away from. But that's not the definition of a poison. A poison is a substance that can cause injury, harm, or death in a living organism. So something that can cause harm. Under that definition, can you think of a single drug that is not capable of being a poison? Anything. I cannot think of one drug that can't cause harm if used, improperly or in the wrong patient. Anything, everything can cause harm in, the right concentration or quantity. Water. Right? You think of water as being like the most innocuous, safe substance that there is. It's just water. Our bodies are mostly water. However, if you give enough of it fast enough, you can actually kill someone. People could die from water ingestion if they ingest a ton of it really quickly. Or if the person has medical conditions that make them less able to tolerate a large volume of water. So if they have chronic kidney disease, or if they have heart failure, that makes them more susceptible to harm from that water. Or maybe, other patient characteristics make them less tolerant of water. For example, think of the patient's age or size. If I have an infant, they can tolerate much less water than I could tolerate as an adult, right? So there are patient characteristics that make them more susceptible to being harmed by that specific agent. In this case, I'm talking about water, but any drug, right, could be considered a poison. So what's my point in this, right? By saying all drugs are poisons. My point is not that, drugs are bad. I'm not telling you that drugs are terrible. I'm, a pharmacist. Like, I think drugs are fantastic. I've seen all the amazing things that drugs can do. My point in bringing this up is to kind of drive into you that you are going to be wielding an enormous power. The power to prescribe is huge. Your patients are going to come to you with complete confidence in your knowledge and your ability. And that puts you in a very important position. They will most likely go home and take whatever it is you prescribe, right? They're going to take this poison and ingest it into their body because you said it was okay. That is massive power. It's a huge amount of responsibility. And I just want to instill to you like that's going to be you who has that power and that responsibility. Throughout this course, I am going to teach you as much as I possibly can about medications and how to use them. As you go out into the real world and you start practicing, my hope is that you will continue learning, right? That you will always be, reading studies and guidelines to keep soaking up information. And that you will, continuously take your time and respect this power that you have so that you can make really good use of it. You're going to be prescribing all day, every day, so it becomes kind of habit, it becomes normal. But again, I want you to really respect the fact that your patients are trusting you and they're putting poisons into their body because you're telling them to. So it's your job to make sure that, what you're prescribing is appropriate for them. I'll get off my soapbox now, guys. So where do drugs come from? Who regulates them? And who, monitors drugs and their safety and whether or not we should keep giving them to patients? In short, the FDA, or the Food and Drug Administration. That's who's responsible for regulating and monitoring drugs. It has not always been that way, though. There, a short time ago, just over like 100 years ago, the drug market was a complete free-for-all, no regulation whatsoever. Elixirs and concoctions were sold without any proof of safety, without any proof that they were effective whatsoever. People made promises about all this stuff that their little, drug, their little elixir could do, when really it was just, super dangerous, cancer-causing chemicals. Over time, though, and usually as a result of massive tragedy, we have developed the regulations that we have in place today. I'm usually not a huge fan of including history lessons with my science. However, I do think it's important for us to understand where we've come from in terms of, drug monitoring and drug safety, at least a little bit. So, I'm not going to test you guys on the names of all of these acts or what year they were passed or anything like that. I just want you guys to kind of see how far we've come. And I think sometimes, it gets a little the whole how hard it is for drugs to get approved. And all of the FDA monitoring sometimes can seem a little bit tedious, and it's easy to get annoyed with how hard that process is. But I think by understanding where we've come from and how far we've come, it allows us to kind of respect the FDA a little bit more and understand the importance of it. So in 1906, the original Food and Drug Act was passed. That is what would eventually become the FDA. This act, though, all it did was just prohibit the sale of food and drugs that had been mislabeled or that had their ingredients fraudulently labeled. That's it. It did not require any proof of safety. It did not require that things had proved to be effective. It's just you had to be honest about what it is that's inside that, thing you're selling. In 1937, the elixir sulfanilamide, that has it has an alcohol in it called diethylene glycol, unfortunately killed 107 people, which showed the need to establish drug safety before marketing. So in 1938, Congress passed the Federal Food, Drug, and Cosmetic Act, which required that new drugs show safety before selling. Again, we don't have to show that things actually work, but at least now when you're selling a drug, you have to be honest about what's in it, and you have to have shown that it is safe. In 1941, there were 300 deaths and injuries that result from the use of sulfathiazole tablets. Sulfathiazole is an antibiotic. However, this sulfathiazole was tainted with phenobarbital. Phenobarbital is a very strong sedative. It's actually like a seizure medication, but it has a very strong sedative effect. So at this point, in response to the fact that this antibiotic was tainted with a completely different drug, the FDA drastically changed its manufacturing controls and quality controls. So these changes led to the development of what we call good manufacturing practices, right? GMP, good manufacturing practices. So the idea of this is, okay, now you have to be honest about what's in there. You have to prove that it's safe, but now you've got to be really careful about how you make it to guarantee that we don't accidentally have, something else inside our drugs. In 1951, Congress passed the Durham-Humphrey Amendment. This defines the kinds of drugs that cannot be used safely without medical supervision. So that essentially created prescription-only drugs. So, now we have prescription-only drugs where you've got to go to the doctor, get a prescription, and get that drug dispensed from the pharmacy. And we also have over-the-counter drugs. Those are things that you can purchase without a physician because they're deemed to be safe enough for you to self-diagnose and use the drug on your own. In 1952, there was a nationwide investigation by the FDA that reveals that chloramphenicol, an antibiotic, caused almost 180 cases of blood diseases. often deadly blood diseases. So 2 years later, so like this is a drug. The drug had been tested for safety. It had been approved, and we were giving it, it was a prescription, but it was being prescribed to patients across the country, and everything was fine. However, it was causing, we didn't know that it did this, it was causing these blood diseases as an adverse drug effect. And, it was happening all over the country. People were getting sick, people were dying all over the country, and we didn't realize it collectively. We didn't know that this was something we should be looking out for when we prescribed chloramphenicol. So, eventually people started to realize, hey, maybe there's a connection. So the FDA launched this investigation, and they found out, hey, yeah, chloramphenicol actually does cause this drug effect. We do need to, test to look out for it when we prescribe chloramphenicol. So 2 years later, the FDA began a program of voluntary drug reaction reporting. And we still have this of adverse drug effects. So we still have this program, and I'll talk to you guys about it later. But if you are prescribing a drug and your patient has an adverse effect, and you're pretty sure that this drug caused it, but it's not listed as a commonly known thing that this drug does, you can report that to the FDA. As in, like, hey, I think this drug actually has another adverse drug effect that we didn't know about. And the FDA takes all those reports and monitors them so that it can look for trends. So if there are doctors all over the country who are reporting that drug A causes low blood sugar, they can see those trends easier and see them sooner so that they can start investigating. In 1962, the thalidomide controversy leads to stronger regulations regarding proof of efficacy. So at this point now, we also have to prove, hey, that this drug is effective for what we say it's going to do. The thalidomide controversy was a really big issue safety-wise as well. There was a drug that we were actually giving to pregnant women for morning sickness, and this drug, thalidomide, caused severe birth defects. We still have thalidomide for completely different things, but we were giving it for morning sickness, and then babies were being born with these birth defects where their arms and legs were not fully formed. I think I have a picture coming up next to show you. Yeah. So here you can see, this is an example of a thalidomide baby. So that shows us kind of the way we got where we are, right? Unfortunately, there were really bad tragedies, and then that showed us, hey, the current system that we have isn't working. We need to do more to protect our patients. And then, legally, we would pass some sort of an act, and that would make it, more strict in some way. And that led us to where we are now. Now, the drug approval process, the things that a drug company has to do before their drug can be prescribed to the general public it's a pretty long and arduous process. And this is to protect us, right? To protect people who are going to be taking the medications. So first we have drug development, right? So this is, research in a lab. They're, creating chemicals that they think are going to bind to specific receptors and cause something to happen. Once they have something that they're pretty sure is going to do what they want it to do, then we first test it in animals. Usually starting with simple animals and then ultimately getting to animals that are, have physiology that's similar to ours. Once you see that the drug is safe in the animal and it does what you are expecting it to do in the animal, then you submit an IND. IND is investigational new drug application. So your investigational new drug application is the application. You show all the animal testing that you have done, show that it's safe, show that it does what you're expecting it to do in animals, and you're asking if you can test it on a very small number of human subjects, right? You want to test it in people. Okay, so once the drug has been, it's been okayed to be tested in humans, this testing is done in, multiple phases. Here, phase 1, 2, and 3 are, testing that are done by the drug company. So first, in phase 1 clinical trials, this is done in a very small number of patients, 20 to 80 patients. These are normal, healthy individuals that don't have the disease. And the idea here is just to show safety. That's it. It's just to show this drug can be taken by humans and it's not going to, cause any huge problems to the people. Like, people can safely take this drug. Once that's shown, then the drug company moves on to phase 2 clinical trials. This is done in hundreds of patients, so now you bring in more people, and these patients actually have the disease. So the idea here is to show that the drug actually works, that it's effective, or it does what you want it to do. So, you have hundreds of if your drug is for high blood pressure, you bring in hundreds of patients who have high blood pressure. You give them the medication, you monitor, and you say, yep, look, this drug works. This drug lowers blood pressure by X amount. It is effective. And still, you're always looking at safety, right? If that works, then you move on to phase 3 clinical trials. These are much bigger. And so thousands of patients, and you're continuing to look at safety and efficacy. We're trying to identify all of the different adverse drug effects that this drug might cause. Again, still looking at and making sure that it's effective and that it works. If the drug gets through all of this and everything is good, then the drug can be approved to be, go out into the world, right? The drug is now prescribed out into the general public. Now, just because the drug has been approved, right, and it's now out in the general public, practitioners are all prescribing it, that doesn't mean that monitoring of the drug is done. At that point, we have phase 4, which is post-marketing surveillance. This is what I was mentioning earlier when I said that, it's important that practitioners keep an eye out for new adverse drug effects that we didn't know about, and that you report them if you notice them. When a drug is being given to patients in a clinical trial, it's a highly controlled environment. The patients are chosen very specifically. The patients typically are not at the extremes of age. They're not really old or really young. The patients typically don't have a lot of comorbid diseases. They don't have a lot of different conditions. They usually just have like that one thing you're trying to treat. They're pretty simple patients, and you monitor them very closely. Once the drug goes out into the real world, you have, elderly patients taking it, really young patients, patients who are on 15 other medications, patients who have kidney disease, like you've got all different types of patients taking the drug. That's when you start to see, kind of the more rare adverse drug effects come up. So the only way that we catch these, that we realize that they're happening, is if practitioners like you report them to what we call the MedWatch program. So the MedWatch program collects data on safety and adverse drug effects from, everybody out there. Now, drug manufacturers have mandatory reporting. If the drug manufacturer becomes aware of a safety issue with their drug, they have to report it to the FDA. You, right, healthcare practitioners are voluntary reporters. You are not going to get in trouble if you don't report something. However, it's very important that you do, especially if you're sure that the drug caused this. Sometimes, you prescribe the drug and, maybe the patient isn't sleeping as well, but they're also really stressed out and they've been having a lot of caffeine and whatever. Well, it's like, the drug is probably not causing that insomnia. There's a lot of other stuff going on, whatever. But there are times when you give a person a drug, they start experiencing another problem. You take the drug away, that other problem stops. Like, in that case, you're pretty sure that the drug caused this other issue. So you should report via the MedWatch program the situation, report what happened. If you're the only one who's ever reported this, then nothing is going to happen. But if the FDA sees that there are hundreds of doctors all over the country reporting the same thing, then that starts to, kind of lead them down the road that, hey, this drug does cause this specific adverse drug effect. And this is important. There are a lot of medications that have problems that we did not know about until post-marketing surveillance. For example, an increased risk of suicide in teenage patients who start taking antidepressants. We did not know about that until antidepressants were out, in the general public and started being given to teenagers in higher numbers. There's an diabetes drug, rosiglitazone, that causes a lot of cardiac issues. We didn't know until post-marketing surveillance. Fluoroquinolone antibiotics can cause tendon rupture. We didn't know until we started giving them to the general public. So this is really important. Don't assume that somebody else will report it, that somebody else will take care of it. Okay, you're a very important part of drug safety. Some drugs have additional monitoring, requirements, specific regulations that have to be followed even after they're approved. So isotretinoin, for example. Isotretinoin is a drug that is given for acne. Doctors who prescribe it, pharmacies that dispense it, and patients who are taking it all have to be part of this iPledge program. And because isotretinoin can cause severe birth defects, so it's very important that patients who are taking isotretinoin are using, birth control in some way, or are ensuring that, they are not going to get pregnant while taking it. So there are very specific regulations. Everybody has to be involved in this iPledge program, and it's followed up very closely. Okay, that's just one example of, extra safety guidelines that are necessary for some drugs because the drug does cause severe adverse drug effects. So like in this case, the FDA could have said, no, we're not going to let this drug be prescribed because the adverse effects are so severe. But they, instead they said, okay, we'll let it be prescribed, but everybody has to follow this very specific or these very specific guidelines to ensure that patients don't get pregnant while taking it. That helped to ensure safety, in patients taking it. Okay, moving on. So when you have an encounter with a patient, right? Patient comes to see you. The most likely result is that you're going to write a prescription for that patient. Now, whether you realize it or not, when you write that prescription, you're going to be employing rational prescribing. there are a lot of different kind of definitions of what rational prescribing is, but it boils down to this. When you prescribe a medication, you use a stepwise approach and make logical decisions to choose the right drug in the right dose, the right route of administration for the right patient at the right time. Okay? Essentially, you think very logically to ensure that you're giving the patient the correct treatment. Okay? Treatment specific to that individual patient. The goals of rational prescribing are to maximize the benefit to the patient while minimizing the potential harm. Also to conserve healthcare resources as much as reasonably possible, and to respect the patient's autonomy. What that means is, like, you're respecting the patient's right to have a say in their own treatment. You don't just go in and do whatever you want to the person regardless of their wishes, right? Patients have a right to understand their choices and have a say in, what's done to them. So maximize benefit, minimize harm, conserve resources, and respect the patient's autonomy. This is essentially the definition of evidence-based medicine. Evidence-based medicine is where clinical judgment, okay, your clinical judgment, scientific evidence from clinical trials, and the patient's preferences all come together. So, like, if you look at this little graph over here, clinical judgment is like, that's, again, your empiric knowledge, the knowledge that you've gained from, eventually your years of practice. You start to see kind of patterns happen. You start to learn, hey, patients react better to this than they do to this. Or when a patient presents this way, they typically need XYZ. Like, that's your knowledge that you've gained by practicing. Your clinical judgment comes into play. Relevant scientific evidence comes into play. Maybe you look at the guidelines, the prescribing guidelines that summarize all of the studies that have been done on that condition. So my judgment, all the scientific evidence and recommendations, and then also, what does the patient want? What do they prefer to happen? That little overlap there in the middle where all of that is coming into play is evidence-based medicine. That's what we should be doing. So, to practice evidence-based medicine, which is what you will be doing, you've got to utilize rational prescribing. Rational prescribing is a process. It's not simple. It's actually very complex. However, you're not going to like sit down in your office and have, these 15 steps that you check off as you go. Eventually, what's going to happen is this rational prescribing is going to become second nature. It's just what you do. Like, a patient walks into your office and you're going to go through this whole process in order to get to the solution of how you treat them. That whole process that you're going through is rational prescribing. Again, it'll become second nature, but at this point, we do have to kind of go through and point out each of the individual steps and each of the important details, because there are little things that you probably have never thought about that you do need to, make sure you start thinking about. So again, let's go over the steps of rational prescribing. So first, diagnosis and prognosis. Diagnosis is like one of the key determinants of therapy. Ideally, a primary diagnosis will have been confirmed before therapy is started. So hopefully you know pretty sure what you're treating before you choose a therapy. However, sometimes we have to start therapy based on what we think the primary diagnosis is. So sometimes we can't confirm it, and we have to make an educated guess on what that primary diagnosis is. And in that case, it's always kind of important to keep in mind what a possible secondary diagnosis is, right? So like if it's not this, it's probably this. So always kind of keep that in mind. But essentially, with diagnosis, what we do is we start by defining the problem. Okay, this is what the patient has. Like, this is what I need to try and fix. The prognosis is important when evaluating the risk to benefit ratio of a particular therapy. So if you don't know, prognosis is like, how do you expect the patient to do, right? Is your prognosis that, the person's going to get cured of this and go on to live a happy life? Is there prognosis that they're going to live 6 months, right? The prognosis is what the expected outcome is for the person. So again, that's important when evaluating, like, hey, should I give them therapy or not? Like, what's the risk to benefit ratio here for this person? For example, this is kind of an extreme example, but I think that this illustrates it for you well. For example, say you have a patient with stage 4 pancreatic cancer. They have a life expectancy of about 4 to 6 months, no matter what you do, right? You could give them chemo, radiation, whatever. They're not going to live more than, 4 to 6 months. Their most recent labs come back and show that the person has high cholesterol. So, okay, my patient has high cholesterol. That's a disease. I can treat it, right? I can give them medicine to lower their cholesterol. But in this specific patient, is it worthwhile for us to start an additional medication to lower their cholesterol? Why or why not, right? I say no. It does not make sense to start another medication on this person to lower their cholesterol. The problems that arise from high cholesterol are long-range problems. Over time, the cholesterol builds up in the vessels and starts to cause issues with blood flow and cardiac issues, whatever. But these are long-term issues. Our patient, unfortunately, is going to die before any of that could even happen. The cholesterol just does not matter in this patient. If this were an infection that would, get very bad and possibly kill them in the next couple of weeks, that matters. That I'm going to treat. But the cholesterol just does not matter. In this case, there's no benefit and there is a risk. Adding another medication can interact with the drugs they're already on. It can cause adverse drug effects. It costs money, right, for the system and for the patient. And it's just a pain to take more drugs. So overall, there's no benefit and there's a lot of risk. So I would just, you tell the patient, of course, you never lie to a patient or hide anything from the patient, never. So you should tell them, hey, your labs came back. I see that your cholesterol is elevated. And explain, in this specific situation, I don't see the benefit to giving you any medication to lower it. The high cholesterol shouldn't cause any problems, in the next 6 months or so. So my recommendation is that we just, let it go. And then you let the patient decide. Okay. All right. So first, diagnosis and prognosis. This is what I think we're treating. I've confirmed it with these tests. This is how I expect the patient to do long term. Next, you need to specify your therapeutic objectives or goals. So, like, what am I trying to do with my treatment? Are you trying to cure something, or are you trying to just relieve the symptoms? Am I going to try and treat two different conditions with one treatment? Is this preventative, right? Am I just trying to prevent something from happening? Like, what are my goals with this therapy? And it's really important that, once you have your goals defined, you're going to choose the most appropriate therapy. It's very important that you choose the appropriate therapy for this particular patient in this specific situation. A lot of times practitioners get in the habit of always prescribing the same drug. A patient comes in and they have high blood pressure, lisinopril 10. Next patient, high blood pressure, lisinopril 10. It's just what they always do. And sometimes that works. However, it's very important to consider your specific patient, their characteristics, their disease, their comorbidities, like this specific patient in this specific situation. For example, right, lisinopril 10 milligrams. Lisinopril 10 milligram tablets, one tablet by mouth daily is typically a great choice for high blood pressure. In the vast majority of patients, that would be a good first-line drug. But that does not mean that you'll prescribe it for every single patient every single time. Each patient, each situation is unique, and it comes with its own set of attributes. It seems simple, right? But it's not, because in medicine, there are always numerous different factors that we have to consider when choosing the most appropriate therapy. We're going to talk about that in a moment. We'll talk about all the different things that you have to consider. But like off the top of your head, think about it. Like, what should you consider when you're choosing therapy? I would say age, right? Age of the patient, comorbid diseases that they have, right? Like, what other issues do they have? Kidney function, liver function. Can they swallow tablets? What other medications do they have? Do they have drug interactions? Have they tried this drug before? Right? Those are all allergies, right? Those are all things that you've got to be keeping in mind when you're prescribing a drug. Okay? All right. We diagnose the disease. We have the patient's prognosis. We come up with, our goal, and we choose the most appropriate therapy for the patient. Once you've come up with your treatment, you will prescribe, right, the drug, right, or start the therapy, whatever it is. So you start your treatment, and you will educate your patient. This is an extremely important step that is commonly bypassed. Okay, educate your patient. Patient education is essential to achieve good outcomes. Okay, good patient counseling improves the patient experience, so they like you. It improves compliance, meaning they'll take the medication like they're supposed to take it, and it improves safety and efficacy of treatment. So the whole gamut is better because you educate your patients well. We're going to go over patient education techniques in a little bit. Okay, so final step is you monitor your therapy or monitor your patient for safety and efficacy. Monitoring will look different in different patients, different diseases, different medications. Some you've got to do lab work frequently. Some you have to, monitor patients every 2 weeks, and then every month, and then every 6 months. Some drugs, you, for the most part, prescribe it and let it run its course. Follow-up and monitoring are different for different things. However, it is essential to know what follow-up looks like in your specific situation and to follow up at those appropriate intervals to guide further therapy. Okay, so I said that rational prescribing involves choosing the right drug for the right patient at the right time. So this means that we have to take patient variables into effect, right? We've got to look at that specific patient and take all of their characteristics into account. We also have to take drug variables into effect. Okay. If you look here, I have, on the left, all the various patient factors that are going to affect our choice of therapy. Age, especially the extremes of age, as in, very old patients and very young patients. But especially the extremes of age will influence therapy choices. And that's because there are huge physical and physiological differences in the very old and the very young. Body size is going to affect dosing with many medications. There are a lot of meds that are dosed based on weight. So how big your patient is. Obviously, the gender of the patient matters, especially if you're giving something, that's hormonal or something that affects the reproductive system in some way. Body composition is also important to consider in addition to body size. Consider the following two patients, right? Say I have a male who is 6'1", 6 feet 1 inch tall. They weigh 220 pounds, and they are a weightlifter, right? Super muscular. And then I have a female who's 5'5", 220 pounds as well, with a very sedentary lifestyle. Both patients are the same weight. So their body size, right? If I'm just doing weight-based dosing, they're going to look like the same patient, but their body composition is completely different, right? Fat content is vastly different in these two patients. The amount of adipose tissue or fat is important in the dosing of certain medications, specifically those medications that are lipophilic, right, that like fat. Drugs that are lipophilic tend to accumulate in the fat, causing a drug depot. So this person who's, the female patient who's very overweight, she could actually have the drug build up and accumulate in her fat, whereas the other patient would not. Okay, so not just body size, but body composition, especially for some drugs. Genetics come into play. Physiological variables, we're going to talk about a lot of these things in a little bit. Pathological variables, tolerance, has the patient been taking this drug for a long time, or is this their first time taking it? And then compliance. So compliance, again, is the patient taking the drug as prescribed or as intended? Drug factors that are important. Again, we're going to talk through all of this stuff, but drug factors, the prescribed dose and the administered dose. So is the patient actually getting what you prescribed? Absorption, distribution, metabolism, and elimination. These are the pharmacokinetics of the drug. Protein binding, does the drug roam free through the blood or is it attached to proteins? Concentration at the site of action. If you're treating an infection in the eye, does this drug actually get to the eye or not? Interactions with other drugs. Side effect profile, right? Some patients might be more sensitive to specific side effects. So maybe you don't want to give this drug to the patient, because they're more sensitive to those specific effects. Intensity of effect and contraindications. Because contraindications are specific reasons why a person shouldn't take this specific drug. Again, I haven't really focused on these because we're going to talk about them. Okay, so when making therapy decisions, there are special populations that require additional consideration. We'll talk in detail about the consideration that's given to children, to the elderly, and to patients who are pregnant or lactating. Because these are our, specialized populations. The field of pediatrics refers to the treatment of children under the age of 18. However, those first 18 years include a huge range of, physiologic differences. A neonate, right, a brand new baby, is very different from an 18-year-old. You do not treat them the same. So you can't just say, pediatric patients get this. Because of this variability, we classify young patients as adolescents, children, toddlers, infants, and neonates. So neonates, that refers to from birth to 28 days. And then infants are babies up to 1 year old. So neonates and infants typically require highly specialized treatment because the baby is so new and their organ systems are not fully developed yet. In general, keep in mind that children are not simply small adults. It's not just that the body is smaller. There are differences in physiology, right? There are differences in how mature the organs are. Vast differences in pharmacokinetics and pharmacodynamics. So differences in how the drug affects the patient, the child, and differences in how the child is able to process the drug. Children have varied body composition with a higher percentage of extracellular fluid and lower or fewer plasma proteins. So this means that drugs that are highly bound to plasma proteins are going to behave differently. There's going to be more free drug, and that drug's going to have a higher or more intense effect in children because of that. Children have decreased enzymatic activity. So that means there's decreased drug metabolism. They have decreased renal function. So until about 3, it takes children get to adult clearance rates at about 3 years old. So until then, they have decreased clearance of drugs. So that means that drugs build up. Even if you gave them the right dose based on their weight, the drug would build up. So the dose has to be lowered even more because they don't clear and metabolize it as well. Furthermore, most drugs are not clinically tested on children. Most of the time, clinical trials do not include kids. So kind of take all of this into account, and this all leads to reduced safety and efficacy in young patients. This is all also going to kind of affect our choice of drug, dose, and monitoring in kids. Also, kind of keep in mind, there are practical things that you've got to think about when you're treating children. Can the child swallow a pill, right? If not, you've got to find a drug that has a liquid form or, make sure you're able to crush it up and put it into applesauce or something. Some drugs can't be cut, split, or crushed. So you have to take that into consideration. Can the child accurately describe, some sort of side effect that they're having? If you have to watch out for, muscle pain with this drug, can the child tell you that they're having muscle pain, or not? If not, how are you going to get around these things, right? Like, what can you do to get around the issues that you have with this specific patient? Older patients represent another special population. The term geriatric refers to elderly patients. The technical definition of geriatric is greater than 65 years old, in the text. Some sources use 70 years of age as the cutoff. As time goes on, our life expectancy is older and older. Patients are healthier for longer periods of time. So some sources have increased that definition, from 65 years old to 70 years old. But in general, geriatric is referring to our elderly patients. So the thing about this, treating elderly patients or geriatric patients, is that older adults constitute a very heterogeneous group. Not all 65-year-olds are the same. Not all 75-year-olds are the same. This group of patients kind of ranges from very healthy and fit, active patients to very frail and, suffering from numerous comorbidities. Because of this, it's very difficult to make blanket recommendations for geriatric patients. Okay, you have to look at your specific patient and their specific patient characteristics in order to make the right decisions. Now, keeping that in mind, there are some kind of trends in physiology. There are some facts that we can, state. So in general, liver and kidney function decline with age. So that puts patients at an increased risk for drugs accumulating, right, and getting higher drug concentrations, and an increased risk for adverse drug events, right, adverse effects. In general, in older patients, we do tend to see more comorbidities. This means like more diseases in one patient. So like one patient with multiple disease states. So comorbidities are common. That complicates treatment. Some drugs, can treat one disease but worsen another. So, that should be avoided in patients who have that specific disease. For example, I mentioned rosiglitazone is used to treat diabetes, but it worsens heart disease. So you can't give it to a person who has both diabetes and heart disease. You would have to choose a different drug. Polypharmacy is common in this population. Poly is many, right? So polypharmacy is like a patient that's taking multiple medications. When someone's taking numerous medications, this increases the chance for adverse events, because you could have, 3 meds that all cause the same thing. It also increases the risk of drug interactions, right? Taking 2 drugs that interact with each other. All of this means that, we have to take special consideration in older patients. There's a lot of kind of increased patient education, increased monitoring, and increased follow-up is typically recommended in older patients. The American Geriatric Society, that's what AGS stands for, American Geriatric Society, publishes what we call the Beers criteria. The beer, or what we call it, Beers list, right? The Beers list. So I posted a link to this in Canvas. I'll make sure it's active for you guys. Or you can just, go on Google and search AGS Beers list or Beers criteria. This is a list of medications that may cause harm in the elderly. Because drug properties and, because of physiologic differences that occur in elderly patients, the drugs that are listed have the potential to be more dangerous in elderly patients. The list gives a recommendation along with a rating of the available evidence. So, it gives you, these drugs have the potential to be more dangerous in elderly patients. This is what we recommend you do. Now, there are a lot of drugs on it, you guys. It's not like a list of 10 drugs. It's huge. And I want to kind of drive into you guys that this is a guide. It's meant to be used as a guide, not as a rule. It does not have like these surefire guidelines that like you have to follow. It's giving you information, and you have to use that information along with your clinical judgment to make a decision. So for example, in hospice or like palliative care situations, these recommendations probably don't apply. For example, like it recommends against the use of benzodiazepines. Benzodiazepines like Xanax or alprazolam can be harmful in elderly. These are drugs that we use for anxiety or like as sedatives. They can cause more issues in elderly patients. But if your patient's in getting palliative care or they're in hospice, this means that the patient is dying. This is end of life care. We're trying to help them to die comfortably. So it's okay to give them this anti-anxiety medication. Like it's okay if it has increased sedation in them. We want that sedation in most cases. So, there are times when the recommendation just doesn't apply. There are also times when there's just not a viable alternative, and the Beers list medication has to be used. We just don't have anything else. In this case, the potential for adverse effects needs to be noted in the medical record. Like in your chart, you need to note, I know that there's an increased risk for adverse events. This is the only medication that we have to treat the patient. This is what I am doing to prevent the adverse effects or make sure that we detect them early. And the patient has to be followed very closely. You've got to educate the patient just to make sure that you're aware of the possibilities. You're following up closely to make sure you catch them early if they occur, and the patient knows what to look out for, and the patient knows what to do if those events occur. Pregnancy and lactation. This is another situation where, obviously we've got to be very careful about what we're prescribing to patients. During pregnancy, you've got to make sure that the drug you're giving does not harm the fetus in any way. And then during lactation, same thing, you need to make sure that the drug is not excreted in the breast milk. If it is excreted in the breast milk, you have to make sure that it's not going to harm the infant. Or recommend that the patient, uses formula instead. So we used to classify drugs as being, like this is what we used to do. Drugs used to be classified as A, B, C, D, or X. Drugs, we have clinical trials, showing that there's no risk to women, who are pregnant. Not very many drugs are A rated because not many drugs are actually tested in pregnant women. All the way down to X, which is saying do not give it to pregnant women, period. We used to use this rating system, but doesn't really give us enough information. So instead, now in the prescribing information, right? Each drug has this whole huge booklet of prescribing information. In that prescribing information, now there's a specific category on pregnancy and lactation. This is what we kind of have now in the new labeling. There's the specific pregnancy category, the specific lactation category, and we now also have information on people of childbearing age, like males and females who have a reproductive potential. Patient education is an extremely important part of your rational prescribing. Poor oral communication from the practitioner leads to about 10% of sentinel events. This statistic comes from a report that was done by the Joint Commission. Sentinel events are either death or serious injury. So problems that resulted in either death or serious injury. 10% of these was because of poor oral communication from practitioners. So the way that you speak to your patients and the information that you give them or don't give them is incredibly important as far as patient outcomes. Good patient education improves the efficacy of drug therapy and the safety of drug therapy. So ensuring that your patient knows why they need to take the drug, right? Like what the drug is going to do and what might happen if they don't take it, is very important because that encourages them to actually take the drug and take it as you've prescribed it. So good education improves patient compliance, right? If the patient doesn't take the drug, it won't work. And ultimately, it is up to them to decide if they're actually going to take it daily or not. So the more you educate them about the importance of it, the more likely they are to actually take it. Also, frequently patients don't take medication because of adverse drug effects, either things that they're worried about happening or things that are happening and make them feel bad. So you can counsel them about possible adverse drug effects, how likely it is that it would actually happen, what to do if it happens, as well as ways to avoid those adverse drug effects. There are a lot of ways that we can avoid adverse drug effects. Simple things like taking the medication with food, taking it with a full glass of water, taking, half in the morning and half at night, taking it at bedtime instead of in the morning. Like these are all things that can be done to prevent adverse effects, but the patient doesn't just automatically know this stuff. You are responsible for counseling them on these specific, ways to prevent adverse drug effects. And I'll teach you all of this as we go through different drugs. Patient education also improves safety. There is a great reduction in morbidity and mortality with good patient education. There's a reduced incidence of drug interactions when you educate your patients, especially with over-the-counter medications. There are a lot of drug interactions that occur between a prescription drug and an over-the-counter drug. Patients need to be aware of this because they can just go buy that over-the-counter drug without any oversight at all and can take it. For example, a lot of antibiotics should not be taken with cations. So with like dairy, with Tums, with calcium supplements, iron supplements. So there are a lot of antibiotics that will not get absorbed if you take them with those other items. You have to tell the patient that. Otherwise, they might have a big, thing of yogurt and take their medication, and the medicine never gets absorbed, so it's never going to work. Or they might take the medicine in the morning and take their multivitamin, and it won't get absorbed, so it won't work. You have to explain this stuff to the patients to avoid those interactions. Good education also decreases the likelihood of overdose and the resulting drug toxicity. Sometimes patients think, oh, one's not working, so I'm just going to take two, which could increase the likelihood of overdose. So they need to be told, all the important dosing information, as well as, interactions that might increase the likelihood of overdose and toxicity. So here you see different strategies for good patient education. First, evaluate the patient's knowledge and correct any misconceptions that they have. There's so much information available online that patients frequently come to us with a lot of bad info. Stuff they heard on Facebook. Our older patients are all on Facebook now, and they get all sorts of bad information. Something their neighbor told them, something their friend told them. You've got to correct all of these misconceptions, respectfully correct them. Use varied methods of communication. So we tell our patients things, right? We talk to them and tell them things, but sometimes it's, hard to, you leave the practitioner's office and don't remember half of what they said. So having things written down can be very helpful. So varied means of communication, verbal as well as written. Use simple language and repetition. And something as far as repetition, ask the patient to repeat back to you. That's very important. So if you're teaching a patient, you're prescribing an inhaler for the first time, right? You talk to them about how to use it, you show them how to use the inhaler, then ask them to show you to make sure they can actually do it correctly. Make sure you tell the patient what the drug is for, what it does, why it's important, and what to expect. Also, tell patients how and when to take the drug, any special instructions involved with taking it. So, like I mentioned, take with a full glass of water. You can't lay down for 30 minutes after taking it. Take on an empty stomach or take with food, right? Take at night, like all these special instructions. Rinse your mouth out after taking it. And then also things to avoid, right? Whether that's, avoid the sun or use sunscreen. Don't, take with dairy products. Don't take any alcohol with it, right? Like all of these specific kind of things. And again, we'll learn all of this. There are so many factors that affect therapeutic outcomes, right? Like we looked at that list of patient factors and drug factors. Now, a lot of different things affect patient outcomes. There are a lot of different variables that you have to be thinking about. We're going to talk more specifically about some of those, kind of really important things. So, factors that affect therapeutic outcomes. Adverse drug events or adverse drug effects are common enough to really warrant attention. Adverse drug events range in severity from, something that's just annoying, like mild dry mouth, right? Mild xerostomia, dry mouth, which probably does not require a change in therapy, to, some drug effects are possibly fatal. For example, angioedema with ACE inhibitors. Angioedema is a swelling of the face and throat and neck. So that, dry mouth, just annoying. Angioedema, possibly fatal. There's a huge range in, how serious adverse drug events are. Adverse drug events can be classified as type A reactions and type B reactions. Type A reactions are predictable reactions that are a result of the drug's mechanism of action. So this is like, because the drug binds to this receptor, it can make this happen, right? We know, we can predict this, like we understand the physiology behind why this is happening, and we know it's a risk. Hypotension, right, low blood pressure, is a known predictable adverse drug effect of ACE inhibitors, beta blockers, vasodilators, right? Like all these drugs that we use for high blood pressure. The drug works by lowering blood pressure. So sometimes it might lower blood pressure too far and cause low blood pressure, right? This is predictable. The toxic effects that occur in an overdose are type A reactions, right? They're occurring because there's too much of the drug, right? So like the drug's mechanism of action is happening too much. The possibility of these reactions occurring is known. They're predictable, so we look out for them. We warn patients about them, and we try to avoid them. So, for example, there are drugs called nitrates, like isosorbide dinitrate. These drugs are vasodilators. They cause our vessels to open up and dilate. They're associated with something called orthostatic hypotension. So, like when a patient stands up, their blood pressure drops really low, and they, get dizzy and lightheaded, and they might pass out. We know that that happens. So when we prescribe these medications, these nitrates, we counsel patients that they need to stand up slowly, right? Don't just hop up from laying down to standing up. Sit up first, slowly stand up in order to avoid, dizziness, lightheadedness, and fainting. We know what to expect. We counsel patients about it. We look out for it. Those are type A. Type B reactions are idiosyncratic reactions. They are not due to the drug's mechanism of action, so they are more unpredictable. Type B reactions are not because of what the drug is doing. They're because of the patient's body doing something. So type B reactions are a result of specific biologic factors in the patient. Frequently, they're immune modulated, so like they occur because of the patient's immune system, or they could be due to some sort of like reactive metabolite that's formed. But for example, allergic reactions are type B reactions. The patient's body, right, the immune system is reacting to that drug and causing this huge response. That's a type B reaction. That is not having anything to do with the way that the drug works. That happens because of the person's body. So a black box warning. Some drugs have what we call black box warnings. This is the strongest warning that the FDA issues. So, it's literally a warning that has a black box around it. Like, that's why we call it a black box warning. When you look at the literature, like the printed out drug information, there's a warning that's encircled by a thick black box. That black box is there to draw attention to that warning, right? To draw your eye to that information. The FDA requires this warning when the drug is associated with significant risk or very serious, possibly life-threatening adverse drug effects. For example, antidepressants have a black black box warning that says they may result in an increased risk of suicidal tendencies in children, adolescents, and young adults, right? I mentioned this previously, that, antidepressants have that increased risk of suicide in young patients. That is very serious. So we put a black box around that warning to make it very noticeable. The fact that fluoroquinolone antibiotics like ciprofloxacin, they have a black box warning about tendon rupture and tendinitis. Those are both adverse effects that we did not notice until after the drug was given to the general public. So a black box warning, guys, does not mean that the adverse drug effect is common. Okay, it does not mean that it's likely to happen. However, it's severe enough to really warrant our attention. It's severe enough for practitioners to make sure they consider it, and that practitioners are careful to try and monitor for it and avoid it. It has been shown, like studies have shown, that black box warnings have the most effect on drug prescribing when there's a lot of media coverage on the drug. As a prescriber, guys, media coverage should not dictate your prescribing decisions or your counseling decisions. Regardless of, media coverage or how much attention something has warranted, you should seriously consider the risks and discuss that adverse drug effect with your patients, no matter what. Okay, patients need to be told that that is a possibility, and you need to talk to them about how to monitor for that event and how to, mitigate that. So, for example, for like the increased suicide risk, patients should, be seeing their counselor more frequently during that period of time when they start the antidepressant. Maybe their family members need to be aware of that risk so that they can watch them a little bit more closely. Follow up with patients should be really close during that initial period of time, just to be extra cautious. So, like, there are things that we do in order to be careful to try and decrease the risk of those effects. Drug interactions. Drug interactions can drastically alter the outcome of, a therapeutic situation. Interactions can occur between two drugs. So a patient can take two medications and they affect each other. The drugs can interact kinetically or dynamically. So when the drugs interact kinetically, this affects like the distribution of the drug, so like where the drug goes in the body. This could affect the absorption of the drug, whether it gets absorbed from the GI tract or not. It could affect how the drug gets metabolized. Like, you could be taking two drugs that are both metabolized by the same enzyme. So they're both kind of fighting for the same enzyme, so each one has a decrease in their metabolism and the drugs might build up. Another example, if a patient takes Maalox while they're taking ciprofloxacin, the Maalox actually chelates, it grabs onto that cipro, so the cipro does not get absorbed. That's a kinetic interaction between two drugs. It affected the absorption of one of the drugs. Pharmacodynamic interactions occur when two drugs work at the same site. So like when two drugs bind to the same receptor, or when two drugs have a similar effect in the body. So for example, like you could have a patient who's taking a drug that lowers their blood pressure, and then you start them on another drug that also lowers their blood pressure. Those effects can combine, and patients, might have really low blood pressure, right? Their blood pressure might bottom out because both drugs decrease blood pressure, and there's a dynamic interaction between them. Drug-food interactions can also occur. Previously, I mentioned, interactions between some antibiotics like ciprofloxacin and dairy-containing foods, like calcium-rich foods like yogurt or milk. Grapefruit juice can alter the metabolism of the statins, which are some cholesterol medications. Again, these are things that you're going to be covering and learning throughout these next 3 semesters. For now, I just want you to kind of understand that these exist. Genetics can play a role in how a patient responds to medication. This is why there's like biologic variability between patients, right? You can give the same exact drug to 2 patients, and the drug might work great in one patient. In the other patient, the patient might process it super quickly and the drug doesn't do anything for them at all. There's genetic variability between patients. We have different biology, different physiology. For example, there are genetic polymorphisms. So like because of our genetics, there are differences in the way that we make the CYP enzymes. CYP, CYP, is for cytochrome P450. So the CYP enzymes, or cytochrome P450 enzymes, this is a huge group or huge family of enzymes that are responsible for metabolizing most medications. So most medicines get deactivated in our body by these CYP enzymes. CYP2D6, 2C19, and 2C9 are involved in the metabolism of most drugs in our body. There are differences in how effective the CYP enzymes are in different patients. So different patients might metabolize drugs really quick or not at all, based on what CYP enzymes they have. About 80% of medications end up being metabolized by these enzymes. And these 3 CYP enzymes right here all have genetic variability. We'll talk a lot more about the genetic polymorphisms and like the way that they affect drug concentrations and drug effectiveness and adverse drug effects when we go through the pharmacokinetic lectures. So in a couple weeks. Compliance. So again, what do we mean by compliance? Compliance is the patient actually complying with the drug treatment? Are they taking the drug as instructed? If the patient isn't taking the medication in the dose prescribed and the way prescribed, then it likely will not work as intended. There are many strategies that we can use to try and improve patient compliance, right? To improve the likelihood that the patient will actually take this drug as intended. First, we've said this a few times, but like impart knowledge. The patient should understand why they're taking the drug, right? So if it's a drug to lower blood pressure, why is that important? It doesn't like high blood pressure doesn't hurt. The person generally can't feel it. So why should I bother taking this medicine to decrease it? Well, they need to know if your blood pressure is left high like this, it can damage your kidneys and cause, chronic kidney disease. It can damage the eyes, right? The retina can get damaged. It can damage your nerves, right? Same thing with like high blood sugar, right? If they've got high blood sugar, like why should I lower it? Why should I bother taking these medicines? Same thing. This can, damage the tiny vessels in the eyes, causing blindness. Can damage the tiny vessels down in your legs, causing, decreased flow to the legs and impaired wound healing and increased risk of amputations. The patient needs to know why it's important that they're taking this specific medication. Communication with the patient, full open communication really helps improve compliance, and communicating with their family when necessary, right, or when the patient allows it. Simplify the regimen as much as possible. Some patients are taking these absurd drug regimens where they've got 15 different medicines. Some of them they're taking up to like 3 or 4 times a day, and it's crazy to take that many medicines. So ways that we can simplify drug regimens. Make sure you optimize the dose of the first drug before adding a second drug. Okay, if you start them on, lisinopril 10 milligrams and their blood pressure lowers some but not all the way, well, increase that to 20 milligrams before you add a different drug. Okay, increase the dose of the first drug, optimize it before you just add something else on board. Consider fixed dose combinations. So there are some pills that come with 2 drugs in one. Sometimes like a specific combination is just really common to give. For example, lisinopril and hydrochlorothiazide. Those 2 drugs both are for blood pressure. They're commonly given together. So there are drugs that come with both in one pill. That makes it easier for the patient to take. Extended release versions. Some drugs only work for a short period of time. So, maybe you would have to give the drug 4 times a day. That's really difficult to remember to take something 4 times a day. So if they make an extended release version, that version patients only have to take, say, once a day or twice a day, and it slowly releases the drug. It's a lot easier to remember to take something once in the morning than it is to take it 4 times a day, right? So make the drug regimen as simple as possible. Or sometimes you can kill 2 birds with 1 stone. If a person, has depression and insomnia, you can give them an antidepressant that causes sedation and just have them take it at night. It'll make them sleepy and also help them fall asleep, right? That's better than having them take an antidepressant in the morning and taking a sedative at night. Finally, is cost. And cost is one that I think we frequently don't think about that much because it doesn't really affect us. We're not the ones paying for it, and we don't really see that aspect of it, right? Like the cost of the drug comes after us, but cost is incredibly important. There are a lot of patients who, have to choose between eating and taking their medicine. And, think about it. What would you choose? Or their medicine and keeping their heat on. And that's very unfortunate that that's the way it is, but that is the way it is. So consider the cost of the treatment and be non-judgmental in your conversations with your patients so that they are open enough to tell you if they can't afford something. Okay. So prescribing errors, unfortunately, have a huge impact on therapeutic outcomes. A prescribing error is defined as a result of a prescribing decision or the prescription writing process. There's a reduction in the probability of treatment being timely and effective, or an increase in the risk of harm. Studies in U.S. hospitals suggest that prescribing errors occur in up to 2% of all medication orders written, and that prescribing errors cause harm in about 1% of all inpatients. That's huge. The hope is that if you have some sort of a prescribing error, the pharmacist will catch it, catch the error, and that this error will only result in, a delay in the patient receiving medicine. So, in the hospital, the pharmacist catches it, they call the practitioner corrects it, and then, great. Or, same thing out in a community pharmacy. You bring the patient brings the prescription to the pharmacist realizes this dose does not make sense, so the patient has to wait longer while they call and get it corrected. So hopefully that happens. However, there are some errors that cannot be caught by a pharmacist. And as a result, the patient gets harmed. So for example, the pharmacist might not know all of the diseases that the patient has. So if they're being prescribed a drug that is going to, worsen their heart failure, but the pharmacist doesn't know that they have heart failure, then they're not going to be able to catch that. Or maybe the pharmacist does not have their most recent lab work. There's information that only the practitioner has. So, not all errors are going to be caught or can be caught by the pharmacist. Prescribing errors can occur for a lot of different reasons. Prescribing errors can occur because the prescriber doesn't have enough knowledge about the patient. So, like maybe the prescriber doesn't know all of the comorbidities that the person has, or they don't know about all of the drugs the person is taking. They don't know about allergies or, reactions that they've had to therapy in the past. They don't know if the person's pregnant, etc. Or maybe the practitioner has insufficient knowledge about the drug itself, which there's no really excuse for. You've got everything available to you via resources. So this shouldn't happen. But, the person might not realize that the dose has to be adjusted in patients with renal failure or elderly patients or, whatever. Prescribing errors also occur because of the omission of information. So this is like when the prescriber, when you are writing a prescription, if you leave off some important info that you should have put on it. This is common in hospitals where like procedures, tests, medication changes are kind of happening frequently. So like maybe forget to put resume pre-op meds. Patients stopped taking, most of their meds before surgery, and you've got to put an order in there to start them again, or they won't be started on them. Or if a medicine is taken PRN is like as needed. So if you say, take this medicine as needed, you have to indicate what it's being taken for. So, take as needed for shortness of breath, as needed for pain, as needed for chest pain. You have to indicate the specific reason that it's being taken. Specific conditions for administration have to, are frequently left off. So for example, you can prescribe acetaminophen, that's just Tylenol, for a temperature above a specific set point. So, patients should take 1 tablet by mouth if temperature is greater than 100 degrees. Okay. Or pain, right? Oxycodone, hydromorphone, these are pain medications. You could say, administer 1 tablet of hydromorphone, 4 milligrams, if the patient has pain greater than 6, right? 6 out of 10, or 8 out of 10. Okay, so there are specific conditions. Sometimes like blood pressure meds are conditional, right? The nurse should only administer the medication if the person's blood pressure is over a certain point. Insulin is a common one. right? Insulin is given conditionally sometimes based on glucose levels. So you've got to include those conditions. Otherwise, it's just going to be given around the clock, and that might be too much. Poor writing can lead to confusion between similarly spelled medications, or doses can be confused. So, for example, 0.1 is frequently read as 1. So we always say that you need to do a leading 0. So don't write 0.1. Instead, here it is. Instead, you should write 0.1. That way, it's less likely to be confused as 1. You do not put lagging zeros. So you do not put zeros after. So don't put 0.10. That looks like 10. Okay, you don't need that 0 there. 0.1 is 0.1. So leading zeros, yes. Lagging zeros, no. Abbreviations. So like 10U is frequently read as 100. The U is for units. So you should actually write it out as use 10 units. QD is the abbreviation for daily. So that gets confused with QID, which means 4 times daily. So now we don't use QD. We just write the word daily. So we just, we make sure that things are written out clearly, which normally nowadays things are typed and sent electronically. But if you're handwriting something, in a chart or on a script, make sure it's clear, avoid abbreviations, etc. And like for the full name of the drug, you write out the full name of the drug. Don't write the abbreviation. Last thing, here or on this slide for things that affect therapeutic outcomes, tolerance or tachyphylaxis can occur. Tachyphylaxis just means like as you take a drug for a period of time, it doesn't work as well. So like it starts working less and less and less and less over time. This can occur decreasing the effectiveness of a medication or a dose over time. So as a person's taking the medication over a length of time, you might have to start increasing the dose, or you might have to change the medication and rotate through different types of medication, over a span of time. Okay. So kind of changing gears here, we'll talk about actual prescription writing. Okay, so like writing an actual script out. When we talk about drugs, right, not all drugs require a prescription. You might recommend a medication to a patient that they can get over the counter, right, that they don't need a prescription for. So OTC stands for over the counter. Literally, the drug is over the counter. It's not behind the counter with the pharmacist. Over-the-counter medications can just be purchased on their own. There's no prescription necessary for them. There is a subcategory of medicines that are technically over-the-counter. They do not require a prescription. However, they are still regulated in some way. So we call these behind the counter because they're frequently kept behind the counter in the pharmacy. So you have to go and ask the pharmacist for them. Again, you don't need a script from a doctor, but you have to get them from, pharmacy staff. Pseudoephedrine is a behind the counter drug. Pseudoephedrine is like the drug that's in Sudafed. It's a decongestant, and this used to just be available free for all, like 15 years ago, 10 years ago, no, about 15 years ago. But pseudoephedrine is used to make methamphetamine. So one way that they tried to curb the production of methamphetamine is by limiting the amount of Sudafed that people can buy. So when you buy Sudafed, you have to give your driver's license, and it gets recorded in this monitoring system. And you can only buy, a limited supply, a limited quantity of pseudoephedrine. So this stops, the people from going in and buying, huge bags full of Sudafed to make methamphetamine. RX only drugs, prescription only drugs, or they're also called legend drugs, are drugs that require a prescription in order to be legally dispensed to the patient, given to the patient, or administered to the patient. When we look at these prescription only drugs, we schedule them. Schedule 1, Schedule 2, Schedule 3, Schedule 4, 5, and 6. Those are all, and then Schedule 7 are all prescription drugs. Schedule 8 are over-the-counter. When we look at those prescription drugs, within this category of prescription drugs, we have controlled substances. Controlled substances are substances that have some sort of addictive potential. So they are regulated more stringently. Technically, Schedule 1 drugs are not prescription. These are controlled substances, addictive drugs that do not have any medical purpose. So like methamphetamine. Methamphetamine is a Schedule 1 drug. But Schedule 2 through 6 are drugs that can be used, as prescription medications, but they are addictive. They do have addictive potential, so we have more strict rules regarding how many we can dispense, refills, how they're given out, etc. So I mentioned that prescription-only drugs require a prescription. So technically, what is a prescription? A prescription is an order for a medication, a therapy, or a device that's given by an authorized person. This order can be given in numerous different ways. So it can be a prescriber's order into the patient's chart. So like you can just enter it into the patient's chart. It can be an order that is written or faxed or like electronically sent to a pharmacy for the pharmacist to dispense to the patient. Or it could be a medication container, like you could actually be giving the person the medicine itself with the label on it. So all the pertinent information is just written directly on the label. I'm not going to like read through this word for word, but these are Florida statutes. These are some of the laws in Florida. A lot of laws regarding medications and dispensing, they are state specific. There are some federal laws that go across all states, but then there are state specific laws as well that kind of guide prescribing in that specific state. So these are some of the Florida regulations. But this right here just tells you what specifically has to be on a written prescription for medical drugs. And this actually does require that it is legibly printed or typed. So the law does state that it can't be messy and difficult to read. It's got to be legible. And then everything it has to have your name, like the name of the prescriber, name and strength of the drug, the quantity to be dispensed, directions. It's got to have the date, and it has to be signed on the day that it was given. Again, it can be electronically issued. That's fine. The quantity, here it just goes through like if it's electronically transmitted, the quantity in numerical format, and the directions for use, the date, and then the electronic signature. So there are, again, more strict laws regarding prescribing controlled substances. So if you are prescribing a controlled substance, these more addictive potential drugs, the quantity of the drug has to be in both text and numerical format. It has to be dated in numerical month, day, year, with the abbreviated month written out or the month in whole. It has to be on a counterfeit proof prescription. Big things here are the quantity in text and numerical format both. The reason for this is if you write a prescription for 10 of something, you don't want the person to just add a 0 and they get 100. But if you write 10 and you have it written out 10, right, then you can't adjust either one. Here's just additional information about what has to be on a prescription for a controlled substance. Patient's name and address have to be on there. Your DEA number has to be on there. In order to prescribe controlled substances, you have to be registered with the DEA. So you need to include your DEA number on there. All of the other stuff has to be on there as well, like the drug information, the quantity, directions, number of refills, and then your signature. One thing is the number of refills is regulated more specifically for controlled substances. I'll talk about this with you guys, in a little bit. But other prescription drugs you can give, they're good for a year if you want them to be. They don't expire for a year. And you could give the patient refills for that full year. You cannot do that with controlled substances. So here are like the specifics for controlled substances. First, C1, right? Schedule 1 drugs. Again, there's no recognized medical use. So methamphetamine, there's no medical use for methamphetamine. It is a Schedule 1 drug. C2 through C5 have these specific regulations. So the drug cannot be dispensed more than 6 months after the right date. So if you write the prescription for the person tomorrow and they go to fill it, 7 months later, they can't. The prescription's no longer good. Only 90 days can be dispensed at a time, so they cannot get more than 3 months worth at a time. And a valid DEA number must be on the prescription. As a prescriber, you're going to apply for multiple identification numbers with different purposes. So a DEA number is required to prescribe controlled substances. You'll also likely get what's called an NPI number. The NPI number is for like Medicare and Medicaid billing. That's different. So you'll have your license number that shows that you have a license to practice medicine. You'll have a DEA number, which means you can prescribe controlled substances. And you'll have an NPI number, which means you can bill to Medicare and Medicaid. So kind of all different numbers. Okay, so these are C2 through C5. C2 drugs are like the most addictive out of the prescription drugs. So these are things like oxycodone, hydromorphone or Dilaudid, morphine, very addictive medications. These C2 drugs have even more strict regulations. So they cannot be refilled. You have to write a new prescription every time they're going to fill it. So you can't, write the script and put 2 refills on it, for them to get for the next, 3 months. No refills. You can, however, write multiple prescriptions at the same time. So say you're giving a person Adderall, right, for ADHD, and you see this patient every 3 months, you don't want them to get 3 months of it at a time. You want them to just get 1 month at a time from the pharmacy. When they come to see you, you can give them the prescription for them to fill right then for 30 tablets, right, 1 a day. You can give them another prescription for the next month and another prescription for the next month. So they can walk away with 3 prescriptions. You write, not to dispense before, or do not dispense before the specific date. So like if I gave them to the patient on September 1st, then I would write another script and I would say, do not dispense before October 1st. And then on the other one, do not dispense before November 1st. Okay, that way they still have their 3 months worth. These scripts have to be manually signed, and if like there's an emergency, so say like a hurricane, the script can be called in, but you have to send an actual hard copy prescription that is, gets to the pharmacy within a week. That's probably will never happen. The other agents, C3 through C5, so these include drugs like alprazolam, right, or Xanax, Valium or diazepam. These agents can be refilled, but it's a maximum of 5 refills. Okay, and again, the scripts are only good for 6 months. So that's where the 5 refills come in. It's like you've got this month plus 5 more refills, total 6 months. So with the opioid epidemic, we have more stringent, kind of more strict laws on prescribing opiates, specific, like pain medications. So we had a new controlled substance prescribing law that came into effect in 2018. This is something that's kind of ever evolving. It's constantly evolving. So as you practice, you'll have to kind of keep up with all of these rules and regulations. But when this came into effect, they created something called eForce, which was a database where you could review all the controlled substances that the person has been prescribed from all doctors, and like the pharmacy can see all controlled substances that have been dispensed. Because before this, you could go to one doctor and get a prescription for hydrocodone and go to another doctor and get a prescription for hydrocodone. And as long as you filled them at different pharmacies, nobody would know that you were doubling up. So now when you prescribe a controlled substance, you're supposed to eForce the patient. And that tells you all the scripts they're getting. And then you enter the script in so everybody is aware of, what they're getting from everyone. This is very important. It prevents, kind of doctor shopping, going to all different doctors. There are also more stringent rules for Schedule II opioid medications. If it's being prescribed for chronic non-malignant pain, so chronic non-cancerous pain, the prescriber has to write non-acute pain on the prescription, like to document that. And then it can be written for, like a month's supply. So if you're, say, a pain doctor and you're treating a patient who has, chronic back pain, they've had a bunch of surgeries, it's well documented that they need this medicine and they're taking opioids, around the clock for the whole month, you can prescribe that month's supply, but you've got to write non-acute pain on the script so the pharmacist knows. If it's being written for acute pain, so the person was just in a car accident, they're experiencing some pain, but it's an acute situation, or they just broke their ankle, it's an acute situation. Opioids, Schedule II opioids are limited to a 3-day supply. Okay, you can only, because the idea is this pain is not lasting forever. After a few days, the inflammation should go down. They shouldn't need this any longer. So 3-day supply. If there is a documented reason for why you think 3 days is not enough. You can prescribe a 7-day supply, but you need to indicate acute pain exception on the prescription. So you need to tell the pharmacist, giving them 7 days, there's an acute pain exception. I expect this to last longer than 3 days, and you need to justify this in the chart in the patient's history. This is meant to prevent practitioners from prescribing these big amounts of opioids for patients who don't actually need them, which is how so many people initially got addicted to opioid medications. You have a car accident and there's some swelling and the back is sore, and all of a sudden you walk away with 2 weeks worth of oxycodone, and by the end of those 2 weeks you're hooked on it. So of course, the person goes back to the doctor and says it still hurts, because when they stop taking the medicine, it does hurt. The whole body aches. So it just kind of turned into this vicious cycle. Taking a medicine for 3 days should not be, does not have the same effect as taking it for 2 weeks, 3 weeks, 4 weeks. Although you should still be extremely careful with, prescribing opioids. Okay, so we know, that prescriptions are required for some medications. So we'll talk about some of the kind of basics of writing prescriptions, because you guys will have to write prescriptions throughout these 3 semesters. I'll give you guys assignments where you'll, have a patient case and you'll have to write the scripts out. You need the patient's name and and another identifier. If it's a controlled substance, you've got to put the address on there. But otherwise, the date of birth is usually used. So their name and date of birth. 2 identifiers should be on there. Put the medicine and the strength. Medicines have 2 names. The brand name is usually like the easy to say name that's given to them by the manufacturer. The generic name is the drug name. Usually kind of that weird, hard to say name. But the drug names typically make drugs easier to group. So, for example, ACE inhibitors all their drug names end in pril. So, lisinopril, enalapril, captopril, those are the drug names. Here, like lisinopril, the drug name is Prinavil. Enalapril, the brand name is Prinavil. For enalapril, the brand name is Vasotec. So Prinavil, Vasotec. You don't realize that those are related to each other by their brand names, but by their drug names you do, right? Lisinopril, enalapril. Here's another example here of cholesterol medicines, simvastatin and atorvastatin. I'll talk to you in a second about writing what you write, if you write for the brand name versus the generic name. You write SIG. SIG means signature, which is Latin for let it be labeled. So that's just a fancy way to say the directions. The SIG is just the instructions for use. So the amount they should take, the route, and the frequency. Okay, so you would write, again, medication name and strength. So like lisinopril, 10 milligrams. And then in the instructions, take 1 tablet by mouth daily, or 2 tablets by mouth twice a day. Okay. The amount that should be given. So how many tablets am I supposed to dispense? And the number of refills. Okay. 0 if you don't want any. Don't leave it blank. And then your signature and all your identifiers. Okay, NPI number, if it's controlled, your DEA number. Here are some common prescription abbreviations. Now that there's so much electronic prescribing, you don't necessarily use these as much, but here are some common abbreviations. Here are all of the route of administration ones. So like PO means per oral, so by mouth. PR, per rectum, so you're inserting something rectally. IM, intramuscular, so that's an injection, IV, intravenous injection, ID, intradermal injection, intranasal, topical, sublingual means under the tongue, so you let it dissolve slowly under the tongue. Buccal is buccal in the cheek. Intraperitoneal, so not as common, but that would be like injecting into the peritoneal cavity. Here are the other instructions. So daily, we just write out. Same thing with every other day, we just write it out. BID is like bi-daily, so twice a day. TID, tri-daily, 3 times a day. QAD is like quad, so 4 times a day. QHS is at bedtime. You could do Q blank H for hours, so Q12H, Q8H, Q6H, Q3H, right? It's like every 3 hours, every 4 hours, every 6 hours. You can also make that like a range, so every 4 to 6 hours, okay, every week. So there's a do not use list for abbreviations that are commonly messed up. I'll let you kind of read through this on your own. Okay, so generic substitution. If there's a generic medication available on the market, it will be dispensed, regardless of what you write for. So you could write, say I write a prescription for Prinavil. Right? I don't say anything about, medically necessary or anything like that. I just write Prinavil, 10 milligrams, number 30, 1 a day, no refills. Prinavil is a brand name. There's a generic available called Lisinopril. The pharmacist will dispense Lisinopril. I wrote for the brand name, but he will dispense the generic. That's the law. You automatically give the patient the generic. If the patient requests the brand name, you can give them the brand name, but most of the time their insurance will say we don't cover it and the person will have to pay cash. So typically they end up getting the generic. The generic is equivalent therapeutically. So for almost all drugs, the ultimate kind of therapeutic outcome is going to be the same, whether you give them the brand or the generic. There can be slight differences in like absorption or like the percent active ingredients, whatever, but the differences are so slight they are not statistically significant, which is why we are supposed to give them the cheapest option or the generic. If the prescriber, if you want the brand name to be given, for whatever reason you think they need to have the brand name, then on the prescription you need to write medically necessary. Those words. Don't write brand only. Don't write don't substitute. Don't write give them brand. You have to write medically necessary. Okay? That tells the pharmacist to give them the brand name, and we code it differently. When it's billed to the insurance, medically necessary is coded differently than if the patient requests it. So it's more likely to be approved by insurance if the physician requests it. But in most situations, there's no reason to do this. Okay, this is a waste of medical funds in almost all cases. There are a small number of drugs where, clinically speaking, there will be a difference between the brand and the generic. It doesn't mean the generic is bad. It just means that there's a clinical difference. So substituting is not the same clinically. So they can take the generic and that's fine. They can take the brand and that's fine, but they're not the same. So whatever you write for, that's what's going to be dispensed. Those drugs that are not substitutable, they're on a list that here in Florida we call the negative formulary. Right, the negative formulary. This is a list of drugs where generic substitution is prohibited. So if the patient wants the generic, you've got to write for the generic. Okay, if you write for the brand, that's what they're going to get. So this is the Florida negative formulary. So Synthroid, levothyroxine, this is really commonly given drugs for hypothyroidism. This is like replacement thyroid. Premarin, conjugated estrogens, chlorpromazine, theophylline. The most commonly used thing on here is the levothyroxine. Again, it's not bad to give levothyroxine. Levothyroxine is perfectly effective. It's just that you can't be switching back and forth between things. So they're not like equivalent. Once you get something, you need to stick with it. That's it. So you can write a script for levothyroxine for your patient. That is fine. One thing I will tell you is there are all different generic manufacturers on these drugs that are on the negative formulary. Don't change manufacturers. Tell your patient whatever the manufacturer that they get first is, they need to stick with it. Because again, any little tiny change in this medication is important. These are some conversions that you guys should be comfortable with, just for like medical math purposes. For example, you might be doing a weight-based dose. Weight-based doses are typically based on kilograms, and your patient's weight might be reported to you in pounds. So you might have to convert their weight in pounds to their weight in kilograms before you can come up with a dose. Or, if you're writing a prescription for a medication that's liquid, you might need to figure out what quantity you have to dispense. So you need to know if they're, taking a teaspoonful twice a day. Well, that means they're taking 5 mLs twice a day, so 10 mLs a day. If they're taking it for 7 days, they would need 70 milliliters. Okay, so I do expect you to know these, to be comfortable with these kind of conversions. Okay, here is some practice here. Okay, so Jane Smith, here's her birthday, has high blood pressure. She needs a prescription for Vasotec or enalapril tablets. She's going to take 5 milligrams twice a day. It comes in 5 milligram tablets. Good, so 1 tablet twice a day. She needs a 3-month supply with refills for a year. Here's her address. So to write this prescription, right, I would write her name, right, Jane Smith, and her date of birth. Okay, I would put today's date on it. I'm going to write this prescription for, I could write Vasotec, and it would be substituted, the generic enalapril. I'm just going to write enalapril. Right, enalapril, 5 milligram tablets. She needs to take 5 milligrams twice a day. So she's going to take 1 tablet BID, right? 1 twice a day. Oh, by mouth. 1 POBID. 1 tablet by mouth twice a day. She wants a 3-month supply. So 2 a day times 3 months, times 90. So that's 180, right? So dispense 180 tablets, and she needs refills for a year. So this prescription is going to get her for 3 months. And then I'm going to need to refill it 3 more times, right? So 3 refills. 3 refills. That'll get her through the next, this is 3 months and then 9 more months. And then I'm going to sign and put all of my info on there. Okay, let's see. Let's look at this script and see if it's good. Okay, name and address, great. Vasotec, 5 milligram tablets, great. Again, you could write enalapril, you could write Vasotec, doesn't matter. It's going to be substituted. 180 of them, good. That's a 3-month supply. One by mouth, BID is one by mouth twice daily. For refills, we put 3 times. Great. Dates on there. You would sign it. You don't need your DEA number. Good. Looks good to me. Okay, John Smith, date of birth 7/2/85, needs a script for drops. He's going to use 1 drop of Timoptic or Timolol, 0.5% solution in his right eye twice a day. It comes in 5 ml bottles. He needs 3 refills, so like 3 months of refills. This is his address. Okay, so for the drug itself, Timolol, right? Timolol, 0.5% solution, right? That's what we're dispensing. The drug, the strength, the form. Remember to put the 0.5%, okay? Not just 0.5, because that looks like 5%. Okay, so he's gonna do 1 drop in his right eye is OD, like ophthalmic, and then D is right. OS would be the left eye. So 1 drop, technically drop is GTT. So 1 GTT OD, 1 drop in the right eye, twice a day is BID. It comes in 5 ml bottles. So let's make sure that that 5 mLs is going to last him for a month, right? So 5 mLs would be how many drops? There are about 20 drops in an ml. So 5 mLs is about 100 drops. 100 drops, and he's using 2 a day. So that 5 ml bottle will last him about 50 days. So it comes in 5 ml bottles, dispense 5 mLs, and that's good to get him through the month. All right, so his name is info, Timoptic ophthalmic solution, 0.5%, 5 cc's. A cc is an ml, it's the same thing, so that is fine. 1 drop in the right eye, BID, good. 1 OD, BID. 3 refills, great. So the script's written like this, that's good. Nothing needs to be changed. How long should this initial fill last? We just said that this 5 mLs is going to have 100 drops in it. If he is using 2 drops a day, that will last him 50 days. And there's spillage involved. Drops can be of different sizes, so that's kind of an estimation. You know, this might end up lasting him about 30 days in reality, but we know that it will, at least it'll be good for a month. He'll be fine for 1 month with this. All right, guys, that is it. I know we covered a broad range of information. This at least gives you kind of an introduction to, pharmacology, the kind of stuff we're going to be learning about how the drugs work, and how pharmacokinetics about drugs, how we're going to prescribe them, the types of things we're going to be thinking about when we're prescribing, and then ultimately how the prescriptions will be written. Okay. In our next class, we'll start talking more specifically about like the actual scientific aspects of pharmacology. That's why I wanted to get this first kind of introduction stuff over with in a video. All right, thanks for watching, guys. I will see you in class on Friday.